Good afternoon. I'm here for one last time. So we will wind up as quickly as we can so that you can move on to the rest of the surgical topics. This is what most people are doing after a good afternoon lunch. Let me see how much I can put you to sleep even more than what you are. So when somebody presents to us with metastatic disease, I think clearly the most important goals, right? Not goal, it goals are one is to see if you can make that patient live longer. The second, an equally important goal, is to make sure that this patient also lives better. So it's not just living longer, but it's also important to make sure that this patient will live better. So when somebody comes to you with extensive disease and based on organ function and performance status, you feel that patient is fit to take systemic therapy, then these are the many things that we end up doing. We test for some biomarkers. Now, what's a biomarker? A biomarker is something that you look for. It might be in the blood, it might be in the tissue, to tell you that a particular treatment is likely to work better. So I've made a list of biomarkers that are shown in your slide. There's something called PD-L1, which helps you to determine whether immunotherapy is likely to be beneficial or not. And then we spoke in the morning, rather we made a passing mention about MMR or MSI high. This is again a very strong marker to tell you that this patient is likely to benefit from just using immunotherapy. You probably don't need chemotherapy at all. And then there's something called as claudin, and then we are looking for, probably we will look for, come September, also another target called FGFR2 beta, and then HER2. So these are multiple markers. I don't want you to try to memorize all of these markers. This is not meant for you. The point is that all of these are necessary to be tested, assuming that your patient has got access to all of these targeted therapies. There is no point in testing for a marker, finding it to be positive, and then saying, okay, you don't have access to this particular treatment. So that is equally important. Now, when we test more, we are obviously likely to find more than one biomarker in certain situations. What do you do when you find more than one biomarker? I don't think we have a good answer to that question as of now. It will again depend upon access, affordability, toxicity, and so on and so forth. Vamsi mentioned about doublet chemotherapy versus triplet. We generally don't use a triplet. We almost always use two drugs. That's why we refer to it as doublet chemotherapy. Do we know that one immunotherapy is better than another? We just don't know. Based on the expression of PD-L1, we decide on which immunotherapy is appropriate for that particular patient. So that's roughly how we kind of work through the maze of multiple treatments and markers that we have for patients with advanced disease. Why do we do all of these? Because here is a picture that is showing you that if you really tested and used the appropriate biomarker, then you're likely to improve the overall survival for your patient. And we also know that in at least most of these studies, there's also quality of life evaluation, which says that at least the quality of life is preserved, not necessarily better except in maybe certain parameters, when you add this targeted therapy over on top of whatever chemotherapy you have planned. So that is exactly why it is important to do markers if you have access to treatment, and then make sure that you use that treatment, because that is likely to improve your overall survival. Now, whenever you have a patient presenting to you, you always put your best foot forward, which means that you do the most appropriate and the best treatment first line, because there's always a thought sometimes that, okay, let me not do this treatment now, let me do this treatment later. Now, that was a concept that we used to follow maybe some years ago, but we don't do that anymore. As long as you have access to a treatment your patient can afford, your biomarker is positive, it's important to use that treatment in the first line and not later lines. One of the most important reasons why you don't use it in the later lines is that when patients progress on first line therapy, nearly half of all of these patients will not be candidates to take another systemic therapy because of various reasons, starting from performance status going down and so on and so forth. So you've lost a chance to treat that patient well and prolong his or her survival. So the concept now is test early, treat with the most effective treatment early. Don't keep your more effective treatments for a rainy day. What about oligometastatic disease? We just don't know how to define oligometastatic disease in patients with carcinoma stomach. It's an evolving area, whether it's lung cancer, breast cancer, whatever it is. But what's important, as Vamsi said, is that it is important to observe the biology of the disease in the patient. Don't rush into doing anything upfront just because it's technically possible. When you treat, if your patient responds well and that response sustains for a reasonable period. Now, what is the number that you will say is reasonable is again very subjective. Is 6 months of response reasonable? 1 year reasonable? We just don't know. But if somebody continues to maintain their response for a longer period, then that is probably a patient where you can go and do some aggressive surgery, remove the mets. Morning they were talking about 1 lobe, 3 mets, stomach. Not all patients come in packages like that, right? You will always have stuff scattered all over the place, and you will have to use your judgment to decide whether to resect that patient or not after watching the disease in the patient for a period of time. The disease teaches you a lot of things. If you are in a haste, you will burn your fingers. You wait for some time, watch the disease, and you act, you are likely to do very well for your patient.